I hope that we talked this morning in a half an hour of years and years of pancreas cancer research, and I hope I get the balance right between those of you that are far smarter than I am and know a lot about this, and others of you that may not be as familiar with the science behind oncology. So you'll pardon me if you feel like I'm either talking down or talking up to you, but we'll do what we can in about a half an hour and leave as much of the specifics as we can for a question period. So some of this we already heard. Joe Hines talked very nicely about staging and some of the issues that the pathologists are looking at in how we think about pancreas cancer. We also learned that if you're squeamish about looking at wonderful pictures of successful operations, don't have a big breakfast. But nonetheless, be thankful that these skilled surgeons do exist. As we like to say, people don't really die of a tumor that has been removed. So by the time they're coming to us, sometimes at the beginning of a disease, sometimes in the middle, or at the end of the stages of disease, we're thinking about different things and we're looking at the disease a little bit differently. So we're going to try to outline some general principles about how I, as an oncologist, think about early stage disease, how I think about disease kind of in the middle, where it is too big to be removed right away in the operating room, but still treatable and often treatable successfully. We'll talk about metastatic disease, and then we'll talk about something that's very important to me, and that is, how do we take care of patients today with the information that we and researchers around the world know, while at the same time always trying to do a better job for those patients today and those that may come our way at some point in the future. And we're also going to talk about survivorship, and I'm going to define survivorship a little bit different. Most of us think about if you can't cure a cancer, then the only other option is to die. And I'm going to give you, and there's probably several of you in this room that are very emblematic examples of how people can live very healthy, normal, active lives with cancer, because I believe that survivorship from cancer happens the day that you get the diagnosis, right? And how you live with cancer and how you make sure that you're living well with cancer is extremely important. So with that said, we've already heard that most of the time pancreas cancer is diagnosed at a stage that is too difficult to go to the operating room. We've talked about staging. And then we're thinking about what are the weapons that we really have, right? We have surgery, we've talked about that. We have prevention and early diagnosis and early detection. That's extremely important. Again, if you can prevent getting the cancer in the first place, it's going to be even less of a problem for me as an oncologist. But then beyond those technologies, we have radiation, and there's lots of different kinds of radiation, the traditional machines, the newer machines, the machines that can do it bigger, better, faster, easier, less side effects. We have chemotherapy, and of course, when everyone hears that word, they think of, you know, the 1970s TV shows where people have lost their hair and have horrible, horrible side effects. And I would say that in today's world, those drugs still do exist. If they work, we don't mind, right? I'll make somebody gladly very, very sick if I can wake them up at the very end of a day or a week or a month or a year and say that they're going to go on and be completely cured. But if I can't promise that cure, then I sure as hell better be able to find a combination of drugs that allows people to live very large, productive, and long lives. And when we talk about, you know, buzzwords like targeted therapy or genetic therapy or vaccines or any of those kinds of things, we're talking about trying to find ways to attack the cancer and spare the normal cells of those side effects. So in some senses, when you take Tylenol for a headache, that's one definition of the word chemotherapy, but at the same time we're trying to distinguish traditional drugs where everything dies, you hope that the good stuff grows back and the bad stuff stays gone, and we also have targeted therapy, if you will. And what we're worried about is that we're going to bump up against resistance or toxicity as a reason for not doing or not curing everybody there. So let's kind of talk about, to try to make this a little bit more real, sort of a very typical case. Someone in his early 60s who has abdominal pain, goes to the doctor, is told that he's under stress. Well, that doctor probably doesn't know that the stress is going to only get worse by ignoring a condition if we're going to end up having pancreas cancer be a part of this person's future. So he's given, you know, pick a medicine that has an advertisement that only if you take it you're going to have a wonderful life, you know, talk about Prilosec or Prevacid or, you know, some some such pretty packaged medicine in the system. So as the patient is getting sicker and sicker, maybe the symptoms are getting better, maybe they're not, patient's losing weight, suddenly wakes up one day and the urine is dark colored and the eyes are yellow. So this may sound like a familiar story for some of you. Maybe you've watched it on TV. This person probably will go on to have 5 or 6 different radiographic examinations, an ultrasound, a CAT scan, an MRI, the endoscopic ultrasound that Dr. Brentnall was talking about. And very typically, the patient is getting shuffled from doctor to doctor to doctor, but ultimately we figure out that there's a pancreas mass. Someone's doing blood work. We heard a little bit about tumor markers, which are the bane of my existence because I don't know what to do with them. I can have people who have very normal blood tests that are on their deathbed. I have people where the numbers, at least once a month or a few times a year, I'll see somebody whose doctor went on a fishing expedition for blood tests. The blood tests are high, and I'm supposed to find the cancer, and many times I can't. So we'll talk a little bit about how tumor markers are a very small piece of the puzzle, but really a small piece at that. They come to a surgical evaluation. We have to figure out what to do. So first there's the idea, and others have spoken about this today, about where should you get pancreas cancer taken care of. And certainly in a city the size of LA, where you have centers of excellence and many of them, you probably want to at least stop by there. And you want to make sure that from that multidisciplinary approach where people who really do nothing but pancreas cancer work all day long is part of your treatment team. Yet there are very many good doctors, often trained in those centers of excellence, who are working in smaller hospitals. So we want to think about whether surgery is appropriate for this patient. We want to think about chemotherapy, and Joe talked about the concept of neoadjuvant chemotherapy. The idea is, at the beginning of a disease, we don't really know which way things are going to go. And our job is to predict the future, and we really haven't been deputized that well to do that. So if we're unsure of a small tumor versus a tumor that might be borderline in its ability to be resected, maybe what we want to do is get very aggressive with chemotherapy or chemotherapy and radiation therapy to answer 2 questions. If the disease is quickly going to spread and not respond, let's focus on treating the patient and extending the patient's life in a different way than making them go through a surgery that's not likely to help them. And similarly, on the opposite extreme, if our treatment called neoadjuvant therapy is going to work, then we feel even better about the fact that surgery is the right thing. And we know which drugs work. We have the ability to look at blood tests and CAT scans to see which drugs work. We look under the microscope to see which drugs work, and we can kind of have a rough guide as to what to do elsewhere or afterwards. I don't want to underemphasize alternative medicine, although that's a really hard word and a broad subject, and I'm happy to sort of talk about specifics because, you know, we all practice in the west side of Los Angeles where people have much different kinds of access to alternative care practitioners, some of which can be very successful, others of which I don't understand. At the end of the day, if someone feels better and their bank account is not too drained, I'm completely in support of it, and I think we need to understand that there are lots of different ways of looking at treatment. So I put that out there, and then clinical trials so that we at least learn from everything that we're doing. So my intention today is not really to make you an expert on chemotherapy drugs, but I'll bet a lot of you have heard of these drugs. This weekend is actually a gastrointestinal cancer symposium. It's in San Francisco, a national meeting that happens every year in January. And whenever there's a cancer meeting, you kind of see in the internet and in USA Today all of these "we've cured cancer today" kind of stories, and you start to see more and more of them. So you may have heard that some of the large-scale pancreas trials have been reported, and we'll talk about a little bit about them and what that means and how to kind of put that in perspective. But really the mainstay of pancreas cancer chemotherapy, traditional chemotherapy, has been a drug that many people think is very appropriately named 5-FU, 5-fluorouracil. The oral drug is capecitabine with the brand name of Xeloda. Gemzar is a drug that came out probably about 10 or 15 years ago. A lot of the studies, because it takes so long to analyze and understand them, were looked at with gemcitabine alone or gemcitabine combinations with platinum drugs. Yes, platinum, the metal. The taxanes is a very nice story with a UCLA connection. The classic drug based off of a YEU tree is Taxol. It doesn't really work very well in pancreas cancer, but its friends and cousins Taxotere, docetaxel, and something called nab-paclitaxel, sort of the brand name being thought of as Abraxane, pioneered here in LA. This is one of the drugs that was just worked on, nanoparticle technology. Then there's irinotecan, and then there's erlotinib or Tarceva, a drug that works by a pathway called the epidermal growth factor, or EGFR pathway, and we'll talk a little bit about this. So we have a lot of drugs that we can use alone and in combination, and the question is which and when and how and all of that, and this somewhat is the science of medicine, and some of it is, I don't know. We'll try to figure it out. So basically, we're going to say that our patient that we're talking about was resectable. Maybe there were some features that made it a bit borderline. So we gave them 4 cycles of chemotherapy. We used combinations of drugs. I'm a believer in that combinations work better than single agents, even though that has often been very, very hard to show in the literature. But the CAT scans say the tumor looks better. The tumor marker is down to make the story easy. The person had surgical resection. Underneath the microscope, you can see that there were dead tumor cells, the term being necrosis. The idea that what we saw in the CAT scans, we also see under the microscope that the therapy worked, but there still was tumor there. There were some lymph nodes that kind of came out with the specimen. There were tumor cells in the lymph nodes, and therefore we're worried that even though the patient has no more cancer in their body, at least visibly, by scanning or by blood tests, we're worried that those cells still could be there on a microscopic basis. And that's the principle by which you're thinking about chemotherapy or radiation therapy after a successful surgery. The idea that we're preventing the cancer from coming back is because we believe at that moment the cancer was still there. Cancer comes back 5 years later or 10 years later, it's the same cancer most often. Lightning can certainly strike twice, but it's the same cancer most often, and if it takes 5 or 10 years to grow back, that's a very different cancer biology than if the minute the patient leaves the hospital, the cancer is back already. So here that CA19-9 is down. It's not normal. Normal values, depending on the lab, might be in the 30s or the 40s. So we sort of struggle, well, is it on its way down? Is it's on its way up? Does it mean anything? And how do we use that? And one can get very crazy by looking at tumor markers. So while I am a fan of looking at them, as I said before, I would look at them with a very small piece, as a very small piece of the puzzle, rather than trying to make too much. So now what do we do, right? So chemotherapy has worked. Surgery has worked. We can't find cancer. More importantly than any of those things I just said, the patient is well, right? When in doubt, look at the patient, because that is often very, very important information beyond just a pathology report or just a CAT scan. And so what do we do now? Well, we can watch, and sometimes that's the right thing to do. We can give chemotherapy. We can give the same chemotherapy. We can change it up a little bit. How long should we give it for? Should we add radiation or one of those techniques? Should we put the patient on a clinical trial? Should we add alternative therapy, or should we use alternative therapy just in difference? So let me introduce you to the bane of my existence, and that are these large-scale clinical trials. And we'll talk about different kinds of clinical trials in a few minutes. But suffice it to say that these are survival curves, right? On the y-axis is what's the probability that the person is alive, and on the x-axis across the bottom is the time in months. Worry when you see a study whose time is measured in days, right? Be very excited when you have months or years. But the problem is trying to find patients that are exactly the same as each other, and even more importantly, exactly the same as you, exactly the same as the person who has pancreas cancer. Because we all know that that's not so easy to capture in a black and white yes or no, 1 or 2 kind of database. And so we have to extrapolate a lot from this information to adapt it to a particular case. People with pancreas cancer can be young or old. They can have lots of other medical conditions. They can have no other medical conditions. They could be in a center where they see nothing but pancreas cancer. They could be the only person with pancreas cancer in the city or in the practice. So it's very, very hard to get a group of people together with meaningful results. And so this is a study that is looking at people whose tumors were too big for surgery, and they were randomly assigned to chemotherapy alone, gemcitabine, versus chemotherapy plus radiation. And you see that blue and yellow is separate. How nice to be at UCLA and talking about blue and yellow, although that's the way the slide came. The world is based at UCLA once again. But you can see that the blue, the combination of chemotherapy and radiation therapy, those people do better. And it would seem to say that chemotherapy and radiation is better than chemotherapy alone. And if all you did was look at a trial like this, you would make that conclusion incorrectly, because I'm going to show you some more data in just a minute, and you also have to kind of dig deep. Well, how many patients did they look at? Were they these centers or those centers? And you can see that this is a really small study. It was a big study, because it was a nice group of patients and reputable institutions, but you can see only about 30 or 40 patients, which is different than the 500 or the 600 that you would really like to be confident of those statistics. And here's another study. This is looking at chemotherapy and radiation, but this time in people whose tumors were already removed, so perhaps a different group, and you can see that the curves overlap. We're looking at something called overall survival on the top and disease-free survival on the bottom. So number one, how long do you live? Number two, how long do you live without pancreas cancer, right? And you'll get the answer of how long do you live without pancreas cancer, how long does it take before your disease comes back, quicker than you will, God willing, with how long you live overall. So the point is really not to focus on these details here, but to say that the studies are a little bit all over the place. And the radiation question is very, very hard to answer because the studies were done before a lot of the newer drugs came into fashion. The studies were done on small groups of people, and we don't know if better chemotherapy can overcome any benefit that radiation adds. So we use radiation in some cases, we use radiation in different cases, and it's one of the questions that we have of an overall theme of individualizing therapy, but it's not a clear idea that everyone should have chemo or chemo and radiation or radiation alone. It's an unanswered question in my opinion. So our patient then did complete a total of 6 months of chemotherapy, and 6 months seems to be that good boundary. Less than 12, studies used to show that 12 months of chemotherapy were better. One day in different diseases we might learn that 3 months is just as good as 6 months, but 6 is kind of that arbitrary amount. We give you credit if you have chemotherapy before surgery. We don't penalize you after. But our patient completed a couple months before, a couple months after, was followed with blood tests and CAT scans, again, the right amount, not scanning every day and not never scanning. But then, unfortunately, the patient had a CAT scan that looks like this, and you don't have to be a radiologist now that you're already pathologists to see those dark spots in the liver, which would be a sign of the cancer coming back. And of course, there's that dreadful moment, either at the beginning of a diagnosis, you have pancreas cancer, or your pancreas cancer has come back, or your pancreas cancer has spread, and automatically people go to the place of, that means I'm going to die tomorrow, or that means there's no quality of life, or that means there's nothing to do. And obviously, none of those are necessarily true. So we have our list, right? And it's a similar list. We might want to add some other radiation or radiofrequency ablation type of techniques depending on where the tumor is and how the tumor is. And at the bottom of the list, I talk about palliative care or hospice care, which is something that's kind of counterintuitive to me. There's a lot of editorials being written, more in the New York Times and such publications, that doctors, particularly oncologists or surgical oncologists or radiation oncologists, are out to just give treatment for the sake of treatment, and there's no reason for it, and we're hurting people and wasting money and wasting people's time. And that what we really should be doing is focusing on disease symptoms or symptoms caused by the therapies. Well, if I wasn't doing that from the moment I first met somebody, that is trying to make them feel better, then I'm certainly not doing my job. So if I'm not doing palliative care, if I'm not helping somebody live better and therefore live longer, whether I do that with chemotherapy or whether I do that with marijuana or whether I do that with an alternative therapy, then I'm not doing my job. And so the very black and white distinction between either we're going to treat in this way or we're going to use palliative care, I think is a bit silly. But nonetheless, it does say that sometimes we can make people better and live longer by using traditional anti-cancer therapy, and sometimes by taking a break in that therapy or by not doing that therapy alone at all, we can also make people live longer or live better. And it's part of that very important discussion that we have with our patients. So what are the issues around chemotherapy? We talked a little bit already about single agent versus combinations. How much proof do we need? Do we have to have a study of 1,000 people in order to make a decision? Can we just pick something out of the pharmacy because we think it worked or our patient yesterday had a very successful outcome? Is it worth it test is again what I was saying before. If we're going to make somebody very sick, the likelihood of benefit has to be higher than if we have somebody taking a pill a day that has no side effects. But more importantly, and this is true not just in pancreas cancer but in all cancers, is the idea that we have to individualize therapy. What am I trying to accomplish? What do I already know about the person in terms of their lifestyle, the disease, how it's behaved already, the biology of the disease? What about their other medical conditions? What are their goals of therapy? What's going on in their family and in their minds? And that individualization of therapy is something that we pull from the literature to help us make sense of the literature, but we can't always make a cookie-cutter decision about every single patient. And so individualizing therapy is just so vital in today's world where we have so many different choices. We have an idea of performance status, that is, how well does the person feel? The person who's out of bed and taking care of herself is different than the person who is in a nursing home and can't get out of bed because they're so sick from some such other disease. We shouldn't be afraid to use experimental medicines, right? Experimental medicines oftentimes are derivatives of existing things, bigger, better, faster, Me Too drugs. Sometimes they're very promising. Sometimes they have no benefit. Sometimes they have no proof. And we have to understand when and where to use them. When do we travel and when do we use alternative therapy? So here are combinations of chemotherapy, right? We have most of the studies saying that Gemzar by itself is just as good as Gemzar plus something else. But just this weekend, the Abraxane Gemzar trial in people whose disease was metastatic, people who have disease outside of the pancreas, did better than people who had Gemzar alone. So you'll hear a lot about that combination. But I think we have to put that in perspective, right? We talk about average survival or median survival. Half the people get Gemzar by itself, half the people get Gemzar and Abraxane. The computer decides which. And then it looks at how many people, how long it takes for the disease to grow, spread, come back, and ultimately what we care about is how long to live. And the median survivals move by a couple months. So you sort of say, really? You know, tens of thousands or hundreds of thousands of dollars to extend people's life by a couple months? It hardly seems worth it. And if you move a little bit further down, Tarceva, a pill that showed an increase in the survival by something around 12 or 16 days. You say, really? You know, is that expensive unless you have stock in the company that manufactures it? But the idea is if the average is moving that far, a couple days, a couple weeks, a few months, several months, then that means half the people might have done significantly better. And you want to look at the tails of those curves. Did some people live years longer, or did everybody live close to that couple months extra survival? So when we hear that studies are positive, the averages have moved, it's a wonderful success compared to history. It tells us that the fact that the disease isn't completely cured means that we still have work to do. But the best available information says that regimen A, in this case a combination, is better than regimen B. And if that's appropriate in that individualizing of therapy, then we want to run with that. You all may have also heard about a combination called FOLFIRINOX. Oncologists too like to come up with acronyms that no one understands. And this is sort of borrowing from other digestive system cancers. If you mix a whole bunch of drugs together, does it work? There was a study done in Europe that looked at that combination compared to Gemzar, significantly higher response rates, and again, people lived longer. And what's nice about that is if you have somebody that has a tumor that is almost but not quite resectable, you want to pick the regimen that has the highest chance of shrinking the disease so you can convert that person to surgical resectability. Now here's a sobering result, and it's not important to be able to see the small letters there, but just that this was a bunch of different regimens and they all look the same in terms of survival. So we have to be able to do better when we're choosing different regimens when we get results like this that may not show us different. And so these are the issues we're thinking about in terms of individualizing therapy. Do we need to get somebody surgically resected so we want to shrink their disease? Because if I shrink a disease on Tuesday but it grows back on Wednesday, I don't really care that I shrank it, right? I'm only shrinking the disease because I think that that's a marker for helping somebody live longer, live better, or perhaps getting to surgery. So we're looking at length of life, quality of life. We're trying to get smarter about molecular predictors of response and chemotherapy assays. So here are all these, just a couple of molecular markers. The idea that we can go to the laboratory and we can predict who's going to live, who's not, who's going to respond to this drug and who's going to respond to that drug, when to use therapy and when to time therapy. And if only it were so simple, my job would be much easier. So the idea is that you're going to find a molecular marker that's accurate. When it says A, definitely this will happen, and when it doesn't say A, definitely that will happen. And unfortunately, our world is not black and white like that, but yet we still need to keep testing and keep trying. And those are the ideas of tumor banks, where tissue is put into a laboratory so that we can figure it out later. That's the idea of helping the individual and also trying to help people that come down into the future. Rhetorical question for me. So here's our person with pancreas cancer, metastatic to the liver. And if I tell you that a few months later we did a scan that looked like this, you're going to say, uh-oh, what did they get, right? Well, this is not difficult to see. This is an old study. It was gemcitabine plus an experimental agent, which turned out not to be any better than gemcitabine itself. But for this particular person, their liver cleared, and their liver stayed cleared for several years, actually. So here's a patient with lung cancer, but I could easily substitute someone with pancreas cancer, multiple prior chemotherapy drugs. This was his CAT scan, and you can see the white tumors in the lungs. And then I can show you the follow-up CAT scan. It's a little bit like going to the ophthalmologist, right? Is it number 1 or number 2? Which is better? Do it again. I need new glasses. But if I tell you that the interval between those CAT scans in a patient whose survival should only have been 2 or 3 months was 3 years on an experimental drug, you would say the following: wow. Number 2, okay, sorry that the patient's disease didn't get cured, but if the patient in those 3 years felt well because he was taking a pill a day, who cares what the size of the tumor is, right? What you care about is how long you live and how well you feel, and you get to put those in that order. So it's really important in a lot of oncology to understand that what we care about most, as I said, is how people feel and how long they live. Along the way, if we can make their cancer disappear, I promise not to be disappointed. Okay? So here's an idea about angiogenesis, and here's this thing: we're going to cure everybody's cancer by shrinking blood vessels. It's involved in a bunch of tumors. Blood vessels and tumors themselves are very aberrant. They're distorted. They're very abnormal. So if you can kill the abnormal blood vessels, you win. And if you can normalize the blood vessels, then perhaps chemotherapy can get into the tumor a little bit better. Here's some nice cartoons which show a tumor cell on the right side of the slide. I don't know my left from my right. It's good that I'm not a surgeon. Along with a blood vessel cell and endothelial cell, and the idea is that they're communicating. The tumor is sending messages to the endothelial cell in the blood vessel to say, grow, multiply, go forth, make new blood vessels, and feed me. And here's another way to look at that, where we have the cell membrane across with lots of receptors picking up signals in the bloodstream that tell the cancer cell to grow, divide, and do all of those horrible things. And on the bottom of the slide, once those signals are interrupted or once those signals are activated, oftentimes that's an opportunity to kill the cell, stun the cell, or improve the delivery of chemotherapy. So animal models are always a first step, right? This is a tumor in mice that was treated with a drug that impedes blood flow, and you can see that the tumor by the end is shrinking. It's going away. It's very, very nice. Here's a model of the cornea where you can see blood vessels on the left. You give the drug, and on the right, the blood vessels are nicely gone. That means that we're going to cure everybody's cancer as soon as we get into clinical results. And here's a drug called bevacizumab, or Avastin, a drug that's been commercially available for about 10 years that is successful in colorectal and breast and brain and kidney cancer. Here was a study in pancreas cancer, did absolutely nothing. Absolutely nothing, despite an early stage study that said we were going to have wonderful improvements in cancer treatment. And unfortunately, when you put the whole big group together, this is what happened. So what happened? We had this wonderful preclinical model, right? We have tumors that are growing more slowly or perhaps even shrinking. So the basic scientist says, look, that yellow curve is below the red curve. You know, we're winning. But to me, growth is growth. Right? So growth is more slowly is okay. It's very hard to convince a patient, don't worry that your tumor is growing, just hang in there because, you know, it's growing more slowly. You're still going to die of a tumor that's growing. So the idea is that in the early stages of clinical trials, oftentimes early promises are not so successful. So on the pessimistic side, when we see a negative trial, we're really disappointed because we really believed in a drug, we really thought it was going to make a difference. But even in the negative trial, is an answer that perhaps there's a small group of patients in that trial with some type of molecular signature who are going to benefit. And if we can figure out who in those early trials or even in those late trials we're going to benefit, we don't have to throw away the drug completely. So though Avastin is not approved in pancreas cancer, there are often times that we would use angiogenesis inhibitors, drugs that work with the blood supply a little bit early. So to finish up, we're going to say that there's lots of different types of clinical trials. It's my personal opinion that every single person with cancer or cancer in their family should be on a clinical trial. That doesn't mean that everybody needs to be treated with experimental medicine, but a clinical trial could collect information about their family history or about their job or their family life. Those kinds of things are so vitally important. We're looking with brand new drugs. That's our focus of our program, brand new drugs straight out of the laboratory. We're trying to understand the dose and the side effects and how well they work, and we always find some wonderful successes. Both of the patients that I showed you were on clinical trials that were brand new drugs straight out of the laboratory, and it significantly, significantly helped them, even though many people are not helped at all. Once we understand how a drug is given, we can study it in a group like only people with pancreas cancer or only people with lung cancer. We then compare it. A phase 3 trial that was talked about a little bit is to compare a good treatment, say Gemzar by itself or a combination of drugs, with our new drug. And that comparison is extremely important. Sometimes placebos are used, but very, very rarely in oncology does a patient get only a placebo. They may get Gemzar plus a placebo versus Gemzar plus an experimental drug, and that's so important as well. We're going to use CAT scans and PET scans to help see things that we don't necessarily see. We're going to combine therapies because we believe that different ways of treating cancer are really the way to go. And then we're going to think about if the first thing doesn't work, what do we do next? Then what do we do? Then what do we do as well? So is there something available besides those chemotherapy drugs that I told you about where we're not curing everybody with pancreas cancer? Absolutely. These are just some of the experimental agents we're working with here. And you could see a similar list at other medical centers in Southern California, let alone around the world. What do we do? What should one do? Find the right medical team, find that right communication, find that right disseminator of information. Make sure there's a multidisciplinary approach. Use treatment appropriately. The idea of chemotherapy for no reason, treatment for no reason is silly. Similarly, the idea of saying chemo is never going to work and it's going to make me only miserable is also wrong because you can always make changes, you can always adjust doses, you can always stop. We're not going to go too far and say that if one person benefited from a drug, therefore you need to take it. So it's the appropriate use of science, not an oversell of science and not an undersell. We're going to be aware of possibilities, the sobering data that we have about pancreas cancer, but that doesn't mean that we don't start the survivorship the day with the diagnosis is made. How do we move forward? How do we live longer? How do we live well? Always having an idea what to do if, what to do next, and being a survivor from day one. What should you do? Are we there yet? The answers are all here. The answers are in the pathology specimens. The answers are in the laboratories. The answers are in the scans. The answers are in the conduct of the brave soldiers, people who are living with cancer at this moment. And the answers are in foundations that are setting the stage for what's going to go for the future. And with that, we'll work on curing the cancer, making the cancer more livable, and finding the what-ifs tomorrow. Thanks.